Welcome to the Therapy Show. I'm Lisa Mustard, your host and guide on this journey of learning and professional growth. Here, we transform the way you earn continuing education contact hours. Whether you're on a walk, on a break in between sessions, commuting, or even preparing dinner, you can engage with cutting-edge insights from leading subject matter experts. Each episode features conversations with seasoned professionals who share effective techniques and tools tailored for busy therapists like you. Our goal is to enrich your practice and fit seamlessly into your active life, ensuring you stay informed and inspired without the hassle of traditional methods. You can say goodbye to sitting in front of a computer screen watching hours and hours of recorded trainings. Instead, we make continuing education as easy and accessible as your favorite podcast. So make sure to visit the website, lisamustard.com, to sign up for our continuing education membership. It's a fantastic way to earn your credits while enjoying the podcast. Join us on the Therapy Show, where your professional development continues wherever you are. Please note that the content provided in this podcast is for informational and educational purposes only and is not intended to replace professional mental health care, diagnose, or treatment. Always seek the advice of your own licensed mental health provider or medical professional regarding your specific situation. While I am a licensed marriage and family therapist and my guests are also professional counselors, the discussions in this podcast are meant to offer general insights and should not be taken as personalized therapeutic advice. Listening to this podcast does not establish a therapist-client relationship with me or any of my guests. If you are experiencing a mental health crisis or have thoughts of harming yourself or others, please contact a mental health professional, call 911, or go to the nearest emergency room immediately. You can also reach out to a crisis hotline such as the Suicide and Crisis Lifeline at 988 in the United States for immediate support. Every individual's journey is unique, and what works for one person may not be suitable for another, so please use discretion and seek appropriate care as needed. Well, hey, friends, welcome back to another episode of The Therapy Show. I'm your host, Lisa Mustard, and this episode qualifies for one continuing education contact hour. It is what I call a Podcourse, which means it's a podcast, the audio content, plus a self-study course to learn more about the learning objectives, Dr. Clarke's bio, all that good stuff. Just head to the link in the show notes where you'll see all of the information to purchase this Podcourse. Dr. Dave Clarke, welcome to The Therapy Show. It is so great to have you.
Great to be with you, Lisa. Thank you.
I'm thrilled to have this conversation. So I guess I'll just dive right into it. We're going to be talking about understanding the prevalence and nature of neuroplastic symptoms. What are neuroplastic symptoms? And can you give us some examples?
Yeah, absolutely. There are probably over a dozen synonyms for this. In the old days, it used to be called the psychosomatic symptoms, but we like neuroplastic because it refers to the brain and nerve circuits that are changed in this condition. And that's what the plastic part means in medical jargon, that there's a capacity for change, which is very hopeful for patients. They are basically pain or illness that are not caused by organ diseases or structural damage. They are instead caused by these changes in the neuroanatomic circuits in the brain, and it surprisingly can produce very real symptoms, pain or illness, anywhere in the body, any level of severity, can go on for years or decades, can be multiple symptoms simultaneously. And yet it's all linked to issues that psychotherapists confront every day in their clients. And many of your clients will have these physical symptoms, but in traditional mental health training, those issues are left to people who went to my kind of graduate school, which is medical school, to deal with. When the physicians can't find anything wrong with the patient, their training is all about organs and structures. And when those are okay, or when you find something and it's not responsible for the symptoms, it's kind of like they're at a loss. If the patient goes to a psychotherapist, the psychotherapist is not going to want to deal with somebody who's got migraines or chronic fatigue or irritable bowel. So these patients get left in this giant blind spot in the system, which might be okay if it was rare, but it's 20% of the adult population, 40% of everybody who goes to the doctor, 50 million people in the United States alone comfortable with this were able to take their existing training and graft a few extra ideas onto that, which we're going to talk about today, they can be dramatically effective with this. I've seen patients with symptoms for very long periods, in one case, 79 years, who was successfully treated for this. People with severe enough symptoms to be in the hospital successfully treated for this using a mental health approach. It's slightly different, some additional new ideas, what we call neuroplastic psychology, that are over and above what you do with cognitive behavioral therapy, for example. But they're not difficult techniques to learn. We've got all kinds of training capacities and resources on symptomatic.me, the website of the nonprofit. When people learn how to do this, they love it. Everybody who's learned how to do this appreciates the dramatic impact they can have.
Fascinating. I'm all in. What do I need to do to learn how to treat these? What are the symptoms? What are we dealing with? What does it look like when somebody shows up in our office?
Yeah, you're right. I didn't fully answer that part of the question. It is symptoms literally from head to toe. There are at least 100 different kinds of things that can be manifestations of a neuroplastic condition. But, let's start at the top. Migraines, ringing in the ears, dizziness, visual disturbances, temporomandibular joint pain or stiffness, trouble swallowing, pseudo seizures, chronic fatigue, long COVID, all kinds of chest and breathing problems. A big one, and I should have mentioned off the top, is low back pain, pain anywhere in the spine. A study in the last year found that 88% of people with pain in their spine, it's not structural, it's neuroplastic. Irritable bowel, pelvic pain, genital pain, certain kinds of rashes, joint pains, fibromyalgia. I'm sure I'm leaving some things out, but the only common denominator is that people can have more than one symptom at a time. My personal record patient came to me with a printout from the internet on which he had circled 27 different individual symptoms that he personally was suffering from. He was successfully treated. In about 30 days, all of his symptoms were gone just by identifying the underlying issue. So, yeah, it's a lot of different manifestations. And, if you talk to your clients about how they're feeling physically, you're going to hear these things because there's a huge overlap in the population that seeks psychotherapy.
Sure. If it's not actual pain from a structural issue or some type of injury, what's going on?
What is that? The brain can actually generate a sensation of pain in your body. The classic example is phantom limb pain, where somebody who's had an amputation will feel pain at the site, not always, but they can feel pain at the site of their missing limb. The brain is generating that sensation, even though the limb is gone. The brain is capable of doing this in people who have perfectly intact bodies. Another example that my colleagues and I love to show in our presentations is a photograph published in the British Medical Journal in the mid 1990s of a construction worker who had an accident in the workplace, impaled his boot on a nail. And the picture shows the nail, the sharp end coming up through the top of his boot, just looks agonizing. And indeed, the patient was in extreme pain. He was rushed to the emergency room, given morphine, and then they carefully cut the boot away. And I should illustrate this. I'll grab a pen here. They carefully cut the boot away. The nail was going neatly between his
Mhm.
toes. He didn't have a scratch.
Right.
As soon as he saw that, of course, he was fine. But it just shows the power of the brain to create symptoms in the body. And it can do non-pain symptoms as well: trouble swallowing, diarrhea, constipation. One of my patients had a completely paralyzed stomach, the organ, not the abdomen. We tested and we have a specialized test for seeing how well the stomach can empty its contents. We have normal values that show the speed with which the stomach is supposed to empty. His stomach didn't empty anything. They called me from the scanning room and they said, "We've been scanning him for 2 hours and nothing is happening. Do we need to keep going?" And I said, "No, we have our diagnosis. He's got a paralyzed stomach." And it was 100% neuroplastic because when we identified the underlying stress and successfully addressed it, he was fine after that.
Wow. I do recall hearing about the construction worker in the boot. I must have heard that in a training before. It was bringing back some memories, and I was trying to place where I heard that. I do recall at some point in my career, I've learned about psychosomatic symptoms, but now we're calling them neuroplastic symptoms. So I just find this really fascinating. Are you tired of sitting in front of a computer to watch hours and hours and hours of recorded trainings so you can get your continuing education requirements fulfilled? Look, I was, and I decided to do something about it. I have created convenient on the go learning that's completely audio based. I call them pod courses. Well, what's a pod course? Think of it as a hybrid between a captivating podcast and a self study course tailored for you, my perpetually busy counselor friend. In my pod courses, you can explore subjects like addiction issues, ethics and values in counseling, holistic approaches, and much more, all while you're on the move. Whether you're commuting, jogging, relaxing at home, whatever, pod courses blend your favorite podcasts with enriching self study courses, perfect for those always on the go. How it works. So tune in anywhere, anytime. Enjoy the pod courses on any device wherever podcasts are available. Quiz yourself, solidify your understanding with a brief quiz after each pod course. Then, last but not least, certify your smarts. Achieve a score of at least 80% to receive a certificate of completion. If you're curious to learn more about my pod course offerings, head to the link lisamustard.com/pod courses or just click the link in the show notes. Pod courses are brought to you with pride by Mustard Consulting LLC, your trusted NBCC ASAP provider. So, what do we do as therapists if we have this client that comes to us? How are we assessing for this in our offices?
It's so important to be open to doing this because there are a lot of significant mental health issues that manifest primarily physically. So that if you are not able to assess people for what's going on that is producing these physical symptoms, the chances are you are missing something really important about what's happening to your client. So being able to assess this is really useful.
Okay.
So what I do is, first you want to make sure they've been to the doctor and gotten checked out, and there's not an organ disease or structural damage that is happening to them. Typically, the patients will have been to multiple doctors and specialists and alternative healthcare providers, and they'll have tried all kinds of supplements and devices, and nothing is working. They're kind of at the end of their rope most of the time. The first thing I assess for is the same thing you're normally going to do. What kind of stresses are happening in your life right now? Can you find any connection between when and where those stresses are happening and the fluctuations up and down in the level of your symptoms? And you may not find a direct chronological link there, but if you do, that's going to give you strong evidence that these life stresses are linked to the physical manifestations. And, a very simple example of that was a patient of mine, and none of the other doctors asked him this, but he only got his pain when he was driving to work. When he was driving home from work, he was
Okay.
fine. On the weekends, when he was not at work, he was fine too.
Mm-hmm.
So my next question was, well, how are things at work? They were not so good. The duration of his pain corresponded exactly to a big spike in the stress level in his workplace. So it was pretty conclusive what was going on. And just by showing him this connection, which he had not consciously figured out at that point, helping him to see that was a big relief because he could finally have a valid explanation for what was happening. And on top of that, he had some ammunition now to go to his supervisor and say, look, we got to make some changes. And that worked very well for him. Another thing to look for is, was there any big stress or trauma that happened right before the symptoms began? And that is a question that is often neglected. People who went to medical school. It happens all the time that I find something that was the instigator or the trigger or some cases the trauma that started this thing off. A great example was shared with me by a colleague who works in Arizona. And there was a woman who'd been going from doctor to doctor for unexplained symptoms, and nobody found out until this woman saw my colleague that right before she became ill, she had been a hostage during the robbery of a store. And for 40 minutes, she had a handgun pointed at her neck. And
Wow.
that event happened right before her symptoms came on. And of course, she had other symptoms of post-traumatic stress as well. But if you're not thinking about this kind of thing, if your whole focus is on organs and structures, and you're not aware of the power of the brain to produce real symptoms in the body, you're not going to investigate this sort of thing. So those are all, very, very sort of helpful ideas to start out with. Other ones that I think most therapists can feel comfortable with is if the patient's symptoms are moving around from place to place. A diseased organ, tumor, infection, or inflammation is not going to migrate from place to place. Migrating symptoms that fluctuate up and down a lot for no rhyme or reason, that's much less likely to be organ or structure based. Symptoms that have gone on for years or decades, if you've been evaluated by the healthcare system and nothing is found and your symptoms just go on and on and on, very unlikely that a serious organ disease is not going to progress and become manifest over that period of time. So, many of my patients have been ill for 10, 20 years. As I mentioned, my record patient, 79 years, another one, 55 years. Both of those patients were successfully treated, finding the underlying condition. Another one is when the patient gets better on vacation. A lot of doctors don't know to ask for that, but if somebody gets better on vacation or they get better or they feel better in a safe environment, but get worse in an environment they consider not to be safe, that's another clue. Those are good places to start. There's a lot more to it, but I'll
Wow.
stop there for now.
It's fascinating. That's so helpful. I'm thinking of personally when some of my symptoms kick in and when they don't, I'm like, oh, okay, it really is a commentary on how we allow trauma, stress, or our environment to impact us, and we don't even know it's going on. I guess I was curious, like, what role does or what type of role does early life experiences play or family dynamics maybe play into some of the symptoms that people might be showing?
Lisa, the audience is going to think I planted that question,
No.
but that is a brilliant follow-up question. I didn't plant it, but you're absolutely right. The next major area of inquiry after what's going on today is, did you have adverse childhood experiences?
Mhm.
And a majority of my patients with neuroplastic symptoms did have adverse childhood experiences of one sort or another. It's very common for them to say, well, it wasn't that bad, or other people have been through worse than me and they seem to be okay, or I think I'm over it. Even people with some pretty bad stuff will have a tendency to minimize it because, as you well know, none of us has a parallel life to compare ourselves with. So when people look back, they don't have a way to really assess just how difficult it truly was for them. Even people who've been through my very first patient, I stumbled on the fact that she had been through a trauma as a girl. This was back in the 1980s. I was in year 8 of my formal medical training and had absolutely no clue about any of this. And the last thing I expected in year 8 was to encounter a patient I didn't know how to diagnose or treat. This woman was 37, and for 2 years she had been averaging one bowel movement per month, despite taking 4 different laxatives at double the recommended doses every single day. All the tests were negative. She'd come to us from another university. I was at UCLA at the time, and the tests were negative. Asked her about stress and accidentally stumbled on the fact that she'd been sexually abused. Unfortunately, not just once or twice, which would have been bad enough, but literally hundreds of times. But she's telling me this in the same tone of voice that you would use to read a grocery list. There was no evident emotion going on there at all. And if you didn't know better, which I certainly didn't at the time, you would just assume, oh, well, this is 25 years ago. She's processed it and she's moved on. But she's got this horrible intestinal condition and this horrible sexual abuse. Could they possibly be connected? I had no clue. Fortunately, there was a psychiatrist named Harriet Kaplan, certified in internal medicine, and had an interest in these conditions. I sent the patient off to see Harriet and forgot all about her, got back to doing endoscopies. I was in training as a gastroenterologist. And then I ran into Harriet 3 months later in the elevator ride that changed my career and asked her what happened to the patient. And Harriet had cured the patient with about 10 weekly counseling sessions.
Oh,
And I'm going, you can't do that. Alleviate a serious physical symptom like that just by talking to somebody. She
wow.
had. And I thought,
Amazing.
okay, it was pretty discouraging to be confronted with my own ignorance at that stage of my training. So I thought, if I'm going to be a complete doctor, I need to learn how to deal with this at some level. So I prevailed on Harriet to give me a basic framework about how she thought about these things and what she did therapeutically. Once or twice a year, I might run into somebody that actually needs this. Well, without even trying, once I got into private practice, it was 5 or 6 patients a week.
Wow. Oh my
And
God.
there were no Harriet Kaplans in Portland, Oregon, where I was in private practice. So I ended up having to try to treat patients myself. And gradually, I had probably a 5 year learning curve to get decently good at it.
Okay. So is the treatment plan or the model that you use, is it based around what she taught you and you've evolved it or changed it?
Yeah, I learned most of what I know, I've learned from over 7,000 interviews with patients, just trial and error to see what was going to work. And one of the most effective approaches is, when people are saying, yeah, I went through this and I went through that as a kid, but it wasn't that bad. And I think other people have been through worse. I'll ask people, what would it be like to watch your own child growing up in the same environment? Imagine you're a butterfly on the wall of your childhood home and you are watching a child you care about try to cope with that environment. Let's say just for a week. What is that going to be like for you? That gives people a completely different perspective, makes it much more real, much they had to endure. And my follow-up to that is to try to help people understand that because so many of them come out of that experience with their self-esteem not in a good place, I want them to appreciate the heroic perseverance they had to have had to come through that and to begin to try to flip their self-image into a more positive light. And I think that's underemphasized in a lot of psychotherapy, not to pay attention to assumptions that people have about their quality as a human being. If they can look at that early experience as something that they bravely and heroically overcame, it gives them a much better foundation for their mental health is been my experience.
Yeah, I really like that. It's very strength focused, very strength based. It's very much focusing on how resilient this person is and how much they've overcome and showing them that you went through something really horrible, but look at you now and you're able to do hard things. I really appreciate that approach. And I agree with you. I think I would love to hear more of that in the world of therapy as well. So that's a wonderful intervention. What else are you doing with patients?
Well, obviously, we can't go back and change the past, even though we can change how people look at it. We can intervene successfully. And again, this is something that worked for me over the years. We can intervene successfully with some of the long-term consequences that are common in my patient population. These fall into three major categories: personality traits, triggers, and repressed emotions. All three can be important sources of stress for people that are capable of causing the physical symptoms. The personality traits is probably the most straightforward. Kids who are in dysfunctional, adverse, challenging environments often react to those environments, at least the people that wind up in my office react to those environments by trying to fix the problems, trying to, solve whatever issues there are, try to take care of the needs of the people in that environment. They acquire not only the assumption about them being second rate, the impact on their self-esteem or being completely worthless in some cases, but they also acquire traits where they're almost fighting back. They're trying to be, very hardworking, very compassionate, very supportive of others. And they, not surprisingly, they carry those assumptions and traits into their adult lives and sometimes become perfectionists. They may be highly self-critical of themselves. They tend to be constantly on alert. So many of my patients grew up in the moral equivalent of a minefield, and they had to be constantly watchful for something bad going to happen. They tend not to be very assertive for their own needs. They tend to form close personal relationships with people who have needs or issues or problems. So they end up in unbalanced relationships where they are giving a whole lot more than they are getting back. When people can understand how those ways of living, how those assumptions about themselves got started, when they can do that exercise of imagining their own kid growing up in that same environment and how they would feel as they watched, that begins to shift those personality traits. The better you feel about yourself as a person, the less perfect you have to be. The better you feel about yourself as a person, the more you're going to feel like you deserve to be in a mutually supportive, balanced relationship. One of my favorite stories about this is a patient who was in her late 30s, and she probably had half a dozen different neuroplastic symptoms simultaneously for 20 years, ever since she was an adolescent. The issue in her childhood was that her parents were emotionally and verbally abusive towards each other. They didn't physically abuse each other, but they pretty much abused each other every other way. And she was the only child, so she was the peacemaker, trying to get her parents to, calm down a little bit, be nicer to each other. Didn't work. So the consequence of that is that she felt like a failure, that she had tried so hard to fix her family situation and she failed. So, naturally acquired this basic assumption about her own lack of worth. When she was 8, her parents divorced, which you would think would solve her problem to a certain extent. But unfortunately, the parents continued to live in the same house.
Oh, wow.
They slept in separate bedrooms, but they kept living in the same house. So, from
Wow.
her perspective, there was no change at all. She's telling me all the time it wasn't that bad. Other people have been through worse. They didn't drink or abuse substances. They didn't abuse me. I've heard all kinds of stories from other people that were much worse than mine. I don't think it was that bad. She had a beloved niece, 5 or 6 years old. A niece lived in the same town. She would take the niece all the time, take her to lunch, take her to shopping, take her to amusement parks, the movies, take her for the weekend. Absolutely adored this little girl. That was my opening. I said, okay, we're going to imagine this little girl in your childhood household trying to cope with your parents for maybe a week or so. And you are going to be a butterfly on the wall, just having to watch. You can't do anything. You just have to watch your niece try to cope with this. As I gave her that thought experiment, she just stared at me for a couple of minutes. And she was a very verbal person, so this was a major change in her behavior. After a couple of minutes, she said, at the end of that week, I would shoot myself.
Wow.
And that was the first time she had recognized just how difficult it truly had been. And she had gone through this, as I pointed out, not just for a week, but in round numbers for close to 1,000 weeks. It really helped her to recognize the magnitude, gave her a much better appreciation for herself. She was one of these people that had a history of unbalanced relationships since she was an adolescent. She had a new boyfriend about every 18 months and they were all bad. After she had this revelation about how much she had to deal with, she dumped her then current boyfriend the next day.
Wow. And did her symptoms go away?
They did. I followed up with her from time to time and she got physically better. She was without a boyfriend for a year and a half, which for her was about 10 times longer than she usually went without a boyfriend. She
Wow.
happened to be impossibly good looking and she had no trouble meeting men, but she was always choosing the wrong ones.
Hmm.
But after 18 months, she was processing a completely new self-image. As soon as you internalize the idea that you are a person of quality, you are not going to accept somebody in your life who doesn't agree with you.
Right.
Without even trying, she met this guy and they've been happily married for a decade now.
Wow. Wonderful. That's amazing. Now, you said you saw her, was this the one you saw for 10 sessions?
No, the 10 sessions was
Okay.
the patient who was moving her bowels once a
Okay.
month, and the 10 sessions was with Dr. Kaplan.
Gotcha.
That was my very first patient. I would not have had a clue what to do with that patient.
So I'm wondering, how deep are you going with these patients? Are you doing therapy with them to a degree with the interventions? I mean, or do you help them unmask it and then say, okay, now that we know what the issue is, go to a therapist, or are you working with them on this?
No, my practice was such that I didn't have the luxury of lots of repeat visits. I took a sample of my patients once to try to figure out how many visits I was actually having with them, and it turned out to be 1.8 per patient. What I had to do was try to share as much of my perspective as I could in a very short space of time. They could go off to see a therapist, and more recently, there are books, video courses, and a whole lot of stuff on symptomatic.me. There's a 12-question quiz that can help clients get a good sense of whether any of this applies to them also on that website. But mostly my work for the ones who had more serious issues was to try to give them some perspective that they could then share with a therapist who had the ability to see them over time. There's also an app now, since we're in the 21st century, called Curable that has a lot of these ideas in a friendly user interface as well.
That's great. That's really important to know. I guess I'm thinking about therapists out there who might want to specialize in this type of therapy. What else? What other interventions work really well for these types of clients?
We've left out the other long-term consequences of the adverse childhood experiences, the next one being triggers. And for that, I'm looking for any kind of person, event, or situation that is highly stressful for the client because it's linked to the past in some way. And my favorite example of that is a patient who was admitted to my hospital after an attack of severe dizziness and vomiting. When I went to see her, she said, "Doctor, thank you for coming, but don't waste your time." I never heard that from a patient before. So I said, "What makes you say that?" And she said, "Well, I've had this same attack 6 to 10 times a year for the last 15 years."
Oh my
And
gosh.
half of them were bad enough to put her in the hospital. And she happened to be, her home was Palo Alto. She had been hospitalized at Stanford University Medical Center 60 times in 15 years with no diagnosis. They could not find anything wrong with her. When she said that to me, I used that as the title for my first book. They can't find anything wrong.
Mm,
And she'd seen a dozen specialists. A psychiatrist had evaluated her and pronounced her mentally healthy. It turned out that all of her attacks were linked to interactions, direct or indirect, with her abusive mother.
mm,
Her mother had been verbally and emotionally abusing her since she was 3 or 4 years old, and it was still going on. The patient was 50 years old. Mom was in her 70s and was still mistreating her. I was able to find a direct connection between when she was having these attacks and when she was having interactions with her mom. I actually made that the first story in that book. Once we brought that into conscious awareness, I can still remember her looking up at the ceiling and going, "Oh my God, I cannot believe it."
wow.
And in
Wow.
her case, just bringing it into conscious awareness alleviated her condition on the spot. She never had another attack. That's why it's the first story in the book,
Yeah.
because she was cured on the spot. I wish I could do that for everybody. There are certainly people that need years of psychotherapy to achieve the same outcome, but in her case, right on the spot.
Amazing. Wow. Oh my gosh. That's incredible. So no more bouts for her. She was able to, I guess, like you said, when she understood where it was coming from, she was able to move through it. That's great.
I
Wow.
went to see her around lunchtime, which is when I usually went to see patients in the hospital. She'd already been discharged,
Wow.
already the next day gone home.
Did you ever follow up with her to
Yeah,
see?
he
Oh
called me a year later when she was back in Portland and said, I went the whole year without any episodes.
my gosh. That's just amazing. Sometimes you just got to bring it to conscious awareness
I
and move
wish it
through it.
was that easy,
Yeah,
but
so do so
in
do
most
I.
patients, but because she'd already done a lot of healing by age 50, she
Right.
was ready for that message.
Sure.
So there's one other major area which is actually the most challenging for adults who are ACE survivors, which is the unrecognized emotions.
Right.
And as you might guess, these are the negative ones. People don't get sick from being happy, but anger, fear, shame, grief, guilt, I have seen examples of all of them able to produce physical symptoms in the body, anger being the most common. A lot of my patients resemble dormant volcanoes on the outside with boiling magma on the inside, and they're not aware of it. That patient I just described with the attacks of dizziness and vomiting had a lot of anger at her mom. Once it was brought into conscious awareness, she could deal with that. She could feel it. She could write about it. She could put it into words, and she could put boundaries around mom's behavior. Other people, the anger can be completely dormant, or it can sort of explode for minor triggers, and people are going like, wow, why did I react like that? Why did I have this anger outburst over this trivial little trigger? And it's because they've got enormous amounts of these emotions inside that they've learned how to repress when they were kids, and they got very good at it when the emotions begin to start knocking on the door as adults, ironically, as part of their healing process. They can't get out. They can't reach conscious awareness, so they get manifested somatically.
Right. That makes sense for sure. Makes a lot of sense. What other techniques or interventions do you find to be helpful?
I've had a lot of my patients, once they recognize the emotions, do writing about it, journaling about it. Some, that butterfly on the wall exercise where you imagine your own kid growing up the same way you did often connects people with those emotions. And then they can, a common exercise for my patients to do is write a letter, not to be mailed, just to be written to the parent or parents who mistreated them, to put all their thoughts and feelings down, both good and bad. Many of my patients still have positive feelings toward the parent, or they can recognize the parents had their own generational traumas and were doing the best they could. So very much mixed feelings there, but I want my patients to put it all into words, either handwritten or on a computer screen. And the more those emotions they can put into words, the less the emotions need to be expressed via the body, and the symptoms improve.
Mhm.
One of my patients took the letter he'd written to his dad to his father's grave and read it to him. He said it took him 4 or 5 hours to read the whole thing. And by the end, he was shouting. But his symptoms were 90% better after that.
Wow.
Not everybody's ready for that exercise right off the bat. It's can be pretty emotional. There was another patient of mine with long history of irritable bowel syndrome and a very troubled relationship with her dad. And so I made this same recommendation, write him a letter, not to mail it. And she said, no, I'm not going to do that. She would come back and see me every couple of months. She would do her research on the internet, and she would find some crazy thing she wanted me to do to diagnose her further or to treat her in some different way. And I kept asking her, have you written the letter yet? She finally got so annoyed with me about after a year and a half of doing this. She said, okay, Dr. Clarke, I'll tell you what, I'll make a deal with you. I will write 2 paragraphs to my dad, but you have to agree to stop badgering me about this. And I said, I don't think that's going to be nearly enough given the complexity of your relationship. She said, take it or leave it. So I said, okay, against my better judgment. Well, you can probably guess what happened. As soon as she wrote the 2 paragraphs, she wrote a third one and then a fourth one, and then she couldn't stop. By the time she was done, she told me later she had 9 single-spaced pages, and she got a lot better after that. Had
Wow.
not been better at all until she did it.
That speaks volumes to the treatment that's possible out there. That's really something.
Yeah, it was a good outcome for her for
Hmm.
sure. One of my patients was a 16-year-old. His writing skills were not that good. So I had him speak into a recording device. He had a very troubled relationship with his dad, and it helped him a lot.
So it sounds like giving voice to the underlying issue or the trauma and getting it out there and just finally getting it out is going to for a lot of people is going to be really therapeutic and help alleviate symptoms. For those that it doesn't, the ones that it doesn't seem to work with, or they're more of a, what do you do then? Do you keep trying new things?
Yeah, it's really about giving people insight, helping people recognize that the physical symptoms are a form of communication from your mind. Your mind is really trying to tell you that it's distressed about something that you may not fully recognize is going on. And so the task of healing from this is to use the physical symptoms in your body as a signal that there is something going on you're distressed about, and to shift your attention from your body. Obviously, if it's hurting, these symptoms can be completely debilitating. Shifting your attention is not easy, but if you can shift from the body that is demanding attention to what's going on in the mind, my mind is trying to communicate using my body as its language. Let's try to figure out what could be going on. For people with significant and long-lasting symptoms, it's almost always connected to a childhood experience of one sort or another. And again, because none of us has this parallel life we can compare ourselves with, we often don't appreciate the magnitude of it. So we have to have the client thinking about something that you probably can remember, but you're not recognizing the full significance of it. Let's explore that. The patient who had the illness for 79 years was actually a nurse, so she had plenty of medical evaluation and care over the decades. But nobody asked her. She was 87. Her symptoms had started when she was 8. Nobody asked her if anything traumatic happened when she was 8. What happened was that she grew up on a farm in the Rocky Mountains, and there were a bunch of kids in the family. She was the oldest, and a new baby arrived when she was 6. And because, it's a very busy, environment, this is in the 1920s, she was given charge of the newborn as a 6-year-old. And so she took care of that newborn like most girls would take care of a doll. She fed the baby, changed it, played with it, slept with it night and day for the next 2.5 years. Tragically, the baby got appendicitis. This is 1923 in the Rocky Mountains. Baby died. And, huge shock. At the funeral, the whole community is in the church. An uncle points out that she was the only person in the church who wasn't crying. Her guilt level just goes off the scale. She starts having stomach pains shortly after that, tries to alleviate the situation. I'm sure she didn't consciously recognize what was going on in her belly, but she definitely recognized the guilt level and the
Mm.
shock and trauma level, started caring for other people's babies, in neighboring farms. No surprise that as an adult, her career choice was to be a pediatric nurse. Had 4 kids of her own that she raised very carefully, but she's having the stomach pain year after year, decade after decade. Nobody has heard this story. Her own kids didn't know this story about the toddler who died. Her treatment was to write a letter to the deceased toddler asking
Mhm.
for forgiveness. Another aspect of the treatment was to swing by an elementary school at recess and pick out a little 8-year-old on the playground that reminded her of herself,
Mm.
and just imagine what that 8-year-old would have been able to do.
Right.
And she got a lot better.
I'm just thinking of so many people out there that if they had this information, would their symptoms go down? Would they understand it? Could they do this work on their own? And to some degree,
A
it's
lot
true.
of people can.
Hmm.
There are books now. They're on the symptomatic.me. We have videos, even our professional course for therapists and physicians. We deliberately made it without technical jargon. So people who are interested in the science, you don't have to be a healthcare professional. It's pretty clear, these concepts.
Okay. So my next question is if people wanted to learn more, you recommend the website to take the course and watch the videos?
Yeah, we're
Mhm.
very careful to curate everything so that it's evidence-based. I'm telling a lot of stories here today, but there are now randomized clinical trials from across North America have tested the value of this in a rigorous scientific way, and the results have been light years ahead of older forms of treatment. Cognitive behavioral therapy, for example, is one of those older forms of treatment, and it's just nowhere near as good as this approach. The UCLA study compared what we call emotional awareness and expression therapy, which is one of the types of neuroplastic psychology, compared that with cognitive behavioral therapy in the control group. This was a very tough population they were studying, older male veterans. The number that achieved their goal, which was at least 30% pain relief, was 4 times higher in the neuroplastic psychology group compared to the cognitive behavioral therapy group.
Wow.
And there are studies, similar, massively better outcomes from Boulder, Colorado, from Detroit, from Harvard, from Halifax.
Hmm.
So it's not just me and a bunch of stories.
Right. Oh, it's fascinating. And this is your mission. This is what you do.
It's 50 million Americans that have
Yeah.
this,
Yeah.
and the number that are getting the appropriate level of care for this is probably in the thousands. To me, the situation is analogous to discovering insulin and only having 1 in 5,000 diabetics have access to it. It rises to the level of a social injustice as far as I'm concerned.
Sure. And it also probably speaks to the rise of people being medicated that may not need medication, I'm guessing. Is that,
Well, yeah, the opioid epidemic
yeah.
alone, let's not even talk about the psychoactive medications, but starting in the 90s, the main treatment for chronic pain from
Mhm.
this cause was opioids.
Right.
And we all know what that led to, 100,000 overdose deaths a year in the United States,
Right.
when there's this other treatment that is vastly more effective with vastly fewer side effects.
Yep.
And the
And
other benefit is in the process of alleviating the physical symptoms, it changes people's lives. I mean, it's like that
yeah.
patient with the parents who were abusing each other, who went from 20 years of rotten boyfriends to somebody who respected her, with whom she's been happily married for a decade. So directly in parallel with that, we're achieving all the goals we would want from a psychotherapeutic relationship.
Yes. Amazing. And so when you were saying that the research study showed that your treatment was a more effective treatment than I hate that I didn't ask you this at the beginning, but what is the name of the treatment that you have coined?
Yeah, it's got a bunch of different names. I'm
Okay.
calling it neuroplastic psychology so that the
Okay.
terminology is consistent with neuroplastic symptoms.
Okay.
But there are 3 closely related subtypes. Pain reprocessing therapy is the most basic and the simplest to learn. Emotional awareness and expression therapy is kind of one level above that. All the stories that I've been telling you here today, I consider that I practice emotional awareness and expression therapy. And then there's another one called intensive short-term dynamic psychotherapy, which is developed the most in Halifax. A lot of good studies have come out of there, but it's more complex to learn
Okay.
and might probably take a fellowship program to fully understand that one. But the training materials that are out there for pain reprocessing and emotional awareness and expression, I think it's readily accessible for any practicing psychotherapist to graft that onto what they're doing.
Wonderful. And is that on your website?
Yeah, we have the video course there, a couple of them actually. There's a new one that we launched a year ago called Challenging Cases that gets into more advanced levels of this. But again, I think very much something that any psychotherapist can learn.
Wonderful. I am so grateful to have you on the show and to share all the amazing work that you've been doing. So, if folks want to learn more about you, your books, where should they go?
My own website based on the book is stressillness.com.
Okay.
The first book is called They Can't Find Anything Wrong. It's written for patients as a self-help book, but it's got 4 dozen stories similar to the ones we've been talking about that illustrate the spectrum of different kinds of stresses that can cause physical symptoms. And we've got 2 textbooks as well using the older terminology of psychophysiologic disorders. The patients didn't care for the term that had the word psycho in it, so we changed to neuroplastic. We also started back with live conferences last year for people that want to get into this. We're having our next one in Boulder, Colorado, September 28th to the 30th, 2025, 2.5 days where we have world-class experts that come and speak. The evaluation scores that we got for the last conference were literally off the charts and how good it was. And
Wonderful.
people can learn a lot from that. I'll just say that if you come to the conference, you're going to be surrounded by people that just absolutely love this work. Once they have found their way to it, one family medicine doctor took me aside at a conference and said that it had put the joy back into her practice because
Amazing.
all of a sudden, the 40% of people that come through the door of a primary care practice that have these problems that make doctors beat their heads against the wall. Now, all of a sudden, you can successfully diagnose and treat them, and they become a source of personal and professional reward.
I did have a question for a therapist out there who is looking to get into working with this type of patient. Once they take some training and they feel confident and competent in being able to provide, what would you say? I always think about the therapist out there that's trying to build their practice or build their business. Where would they go for referrals? Would they go to pain management doctors? How would they build their caseload to help these patients?
A couple of different ways. On symptomatic.me, we have a practitioner directory, and you can get listed there. There are tons of people that come to our website looking for help and look at that practitioner directory for people who've taken the training. Another way to do it, something that I did to try to reach more people, was I started a class. I marketed it to all the primary care docs and the gynecologists in my community. I'm starting a class for any patient that might have stress contributing to their symptoms, because you have to give the physicians some language to use that they'll be comfortable with in talking to the patients. If you bring this up with a patient in the wrong way, they will want to kick you out of the room. You will hear, "This is not in my head, this is real." In fact, I heard that in a magazine article the other day. A patient with chronic fatigue or long COVID was saying, this can't be a mental symptom. This can't be a mental problem. My symptoms are too severe. But it's not true. You can get any level of severity. One of my patients I was asked to see on hospital day 70 for unexplained abdominal pain. She was getting massive doses of morphine around the clock. Horrendous level of pain, but successfully treated with this approach. Coming back to the idea of the class, give the physicians some help by giving them language they can use with the patients. Just say, if stress is contributing to your condition, it may not be all of your condition, it may be only a little bit of your condition, but you might go to this class
Right.
and see what you can learn, and then present some of these ideas in a classroom format. You have to be prepared for it to be a very small class at first. The patients will go back to their doctors and say, hey, this class helped me, and that will lead to more referrals. It will grow over time, but it may take a few years to get a decent number showing up. And the second thing that will happen is a large fraction of them will want to follow up with you personally.
Thank you so much, Dr. Clarke, for coming onto the podcast and sharing your expertise. I hope those listening will go to the website, and I'll put all the links in the show notes so you don't have to remember them off the top of your head, where you can learn more about neuroplastic symptoms and the approaches and treatment. Thank you again. This has just been fabulous.
Thank you so much for having me. I know that everybody who sees this is going to enjoy doing this work.
Thank you. Please note that the Therapy Show with Lisa Mustard is for informational and entertainment purposes only, and not a substitute for professional medical or mental health advice. Always consult with your therapist, doctor, or physician before implementing any suggestions from the show. The Therapy Show with Lisa Mustard is edited and engineered by Chelsea Weaver. If you're looking to start a podcast or ready to take the editing off of your plate, be sure to visit chelseaweaverpodcasting.com. Well, that wraps up another episode of the Therapy Show with Lisa Mustard. I know there are hundreds of thousands of podcasts out there, and I'm thankful you've chosen to listen to mine. Be sure to visit lisamustard.com to access the show notes and discover all the Podcourses and other continuing education offerings. And I'd be grateful if you subscribe to the show. Thank you.